Welcome back to Fly on the Wall, and we are here. Do we need introductions again, or are we good?
We should probably do quick introductions, because I flubbed the first time, so why don't you do the introductions this time?
You're better at it, but I will do my best. We
All
have
right.
Dr. Glafke on the far left, Dr. Sodergren.
I'm Peter Malinowski.
I'm Dr. Jerry Crete, and this is
John Cadwalder.
And Eric Gadan.
And we're here to talk today about boundaries.
Boundaries. We're going to talk about what that means.
Yeah, what it's like to have boundaries with your clients. Anyone want to jump in?
We're sitting pretty close together for boundaries.
We are.
It's still,
Are you uncomfortable with that?
Very good. This is a circle of trust.
John, it's still clear to me where I end and you begin.
I'm not sure. I think it's all kind of like leads in. I'm not sure.
Merge together. Well,
Yeah.
the first kind of step of boundaries.
That's right. Knowing there is
So
another.
what does it mean to have a boundary? Like, because there may be some folks that are watching here at Souls and Hearts that are wondering, what do you mean by boundaries? At least within a therapy relationship.
Mm-hmm.
Or what do your clients think that means when they come in, right? Because sometimes my clients believe that means we're not going to have a real relationship, because of the boundaries, right? There's boundaries. So it's not really a human relationship. It's a role-based relationship, right? It's a psychologist-client relationship, and it's not really a relationship between Peter Malinowski, and Jane Doe, or whoever the client is. Right?
Less between persons, and you're playing the role of receiver of information and recipient of psychological technique. And then there is practitioner of psychological technique.
Right.
And one who pours the information into the other.
It's very transactional, right?
When I think of boundaries, though, I think of safety, first and foremost.
Mm-hmm.
So and we all need safety in relationships. And so a person coming in may or may not have good boundaries. And if they don't, because maybe different things have happened to them in their lives and so on, by having good boundaries, I create safety in that relationship.
So Jerry, you're talking about how good fences make good neighbors, and even how John and I were teasing how where I end and he begins. So you're saying by boundaries are more problematic for those whose boundaries have been challenged, tested, and have been wounded because of boundary violations.
Maybe, Jerry, can you say a little bit more about how boundaries create safety?
Right. Well, because if I am in a relationship and somebody is, even say physically coming too close to me, I might feel kind of unsafe, like I'm being, controlled, manipulated, and so to have an established sense, sit here, please, rather than right here, means we're creating some safety, we're creating some order, we're having some sense of, okay, what are the guidelines and rules that we know is established, and so we can be comfortable with each other.
Which is some part of the way the frame of the work. You think about it in that regard too. I mean, not in the sense of just the professional aspect and what that means in the sense of formality, but it is. I mean, it's for the greatest good, I think, for the patient and the therapist too.
But some clients don't like the boundaries, right? They don't think they're helpful. They don't think that the relationship would be as good, with the boundaries as it would be without certain boundaries. Like, why won't you hug me? Why won't you, talk to me,
Come to my wedding.
Yeah, come to my wedding.
Sure.
Right. Why, or other types of things, So what kinds of things, how do we understand that? How do we explain that to clients who might not see the boundary, might not see the safety issue as so prominent, but see the boundaries as actually getting in the way of the relationship, right?
Or the work, I think one of the biggest issues that we have to address and clarify is communication between patient and therapist outside of sessions, right? Because if they do build trust in us, then naturally, depending on what they're struggling with, they may reach out and ask us for advice. What do I do here? And there's a natural inclination to want to provide some direction, but are we really helping them, right? And so I think, a lot of times patients can be confused as to like where that line ends. Like, when can I reach out, to you via email, via phone call? And so it's important for us to clarify like what situations warrant that, and how we respond, because really we want them to develop a sense of independence and make their own decisions, and not, we could actually be harming them by trying to make decisions for them. But that all comes in like outside of, in session and outside of session. But I don't know how you all manage that. And
I think it goes back to how we love, because it's kind of where, to the discussion earlier, the sense of where, some of the framework, or really this, that kind of frame is something where it is how we love. And the tough thing about that, I think, to your question, Peter, is the sense of where people do want more for lots of reasons. Some of that may be very natural, very healthy. Some may be more this sense, as Jerry's alluding to, this harm, this injury, what seems to be familiar. But it's really trying to love them in the sense of what's helpful, at least what we believe, right? In the sense of where that part of will and the greatest good, of where, if we do see you at the supermarket, because, the sense of trust and the safety, which is the privacy, which is really, one of the keystones in terms of like how we work, that we're not going to really, in some ways kind of violate that sense of trust. We hold it like to that high of a regard because we care about them, because we love them.
So are the boundaries that you guys hold the same for every client?
You're making me think of self-disclosure, because as therapists, we don't do a lot of self-disclosure normally, but sometimes we do share things about ourselves. And I feel like that is going to be different with different clients. There are some clients that you make a judgment that it makes sense to share a little bit more, and with other clients you don't. And it's going to be dependent on the client.
So discerning where they're at and what's best for them.
Right.
Right.
Yeah, there's going to be certain boundaries that are going to be the same across patients, right? Like, time and space and financials and confidentiality and things like this, right? That are sort of inherent in the therapeutic frame. But then there are other things, like you're talking about, Jerry, that are going to vary depending on the therapeutic needs and what's most appropriate for where they're at in the process and all of that kind of thing.
That's how I think about it as well. There's a certain standard set of boundaries. And then there's a whole separate set. Self-disclosure is a good example. And there's a lot of differences about even how that standard set looks. So for example, there's a lot of differences in the way that therapists, for example, handle touch, right?
Shaking hands in a session.
I was taught that you didn't really shake hands.
I remember, and I have that is something I've made as a general practice, but not everybody does. I'm open to it. It's a kind of because it seemed with some people it's been very much of a strengthening of kind of sending them on their way, and kind of a greeting of strength and compassion. But you're right, with some people it doesn't fit.
Well, and to that point, it's understanding what the meaning of touch is.
Yeah.
Right.
Which is a very subjective kind of experience. So that for some people will be very warm, very welcoming.
Right.
And others that's very, creates anxiety.
And I think it can be both for a person at the same time, right?
Can be,
on
sure.
one hand, they really desire it.
Right.
And on the other hand, it's terrifying because of the associations that they've had in their history to that.
Sure.
So.
With that, I feel like you just have to be natural. I feel like if you're weirdly artificial about it, I don't have a problem shaking someone's hand. But I usually let the person lead. So if they start putting their hand out, hey, it's all right.
And so you don't want to be weirdly artificial and inhuman and rigid, but you also want to be able to describe and address what's going on, to be able to explore what that meaning is, because I could be interpreting and I could be wrong about what it does interpret, especially if it means two things at the same time.
Right.
And so it can be difficult to manage boundaries perfectly.
And sometimes there's a hook in it. Like, so what happens if, extend the hand, normal handshake, but then there's a grip and a refusal to let go. right? This could this could happen at the end of the session when a client doesn't want to leave or feels like she wants to be rescued or something like that.
And that's an opportunity then, right, to talk about that.
Right.
I think for most people that it's just a normal thing.
Right.
But
Right.
if you
That's an
didn't
unusual
detect,
case.
if you detected that, then that would be an opportunity.
Right.
Well, and that's where I think, in some ways, I mean, going back to your comment, Jerry, about natural, I think what's natural sometimes can be a slippery slope. I think it can, just occur, very organically, very spontaneously. But I mean, to your point too, Peter, it's a sense of where, not that you have to analyze everything to death, with understanding in that regard, but it's kind of the sense of where people may still want to initiate contact and not really know why. Well, we're really in the sense of familiarity, and which in some ways could be, familiar to them in the sense of that could be harmful, that seems, in terms of other things they've done too. Or maybe is that pleasing to us? Or what are they trying to give us in the sense of where? So, I mean, the intentions, so to speak, I think are important because that's another way we understand that we're with.
Yeah, I tend to err on the side of handshakes and having some amount of touch unless I have indications that it's not in the client's best interest or they are uncomfortable with it or something like that. Because I think it's an important part of just human relationships in general. So I always offer a handshake at the beginning. I have had some people say that they'd prefer not to, and so that just became our norm. But that's always my custom, is to start and end with a handshake.
Well, and I think from more of an attachment standpoint, for some people it's very powerful.
Right.
Because it's a sense of reconnect with the base.
Exactly. And that's why I do it, because I do operate more from an attachment frame. And so, that eye contact, physical touch, name recognition, and at the end, some reference to our next meeting, so the relationship has a sense of continuation over time. All those are things that help people to feel more secure and to know that the relationship has some stability to it.
And safety, like Jerry was talking about, having safety and what I can count on, what I can expect within this relationship.
Right.
These are boundaries, these are expectations, which have, there's some flexibility and there's some arbitrariness to it, but this is a constancy and a way to be with someone.
Some people, appreciate that for lots of reasons, but one of which is the touch means that we're real.
Right.
Exactly.
Yeah. So I got a little counterpoint to that because I don't do it that way. I respond if there is a hand extended, but I work with a lot of folks that are pretty traumatized, and especially if it's a woman, I'm going to wait because I don't know if I'm going to, and it's a different perspective on it. I don't know if I'm going to burden her with a demand, to actually have physical contact. And if I don't know much about, the history of the case, it's the first session, second session, something like that, I'm more cautious about that.
But I follow, once again, the natural rules. Like, I have a rule in my head. I'm not sure where I got it. But when you greet a man, you put your hand out and shake their hand. With a woman, you wait. And if she extends her hand, then you shake her hand. But otherwise, you don't reach to, I don't know where I got that, but that's just what I do.
Is that a Canadian thing?
No,
I don't know. I think it's a Southern thing.
But yeah, because I've noticed that makes sense for me, and that's how I feel. It's like you should, you shake a man's hand. It's like indication of type strength type thing. And I'm coming to mind somebody's like, no, that wasn't a good handshake. We need to do another one. That's a real handshake. So, and whereas with some, I know, and that resonates with me as well. Like there are individuals that it's just not. I don't want to put that burden of contact on her.
Well, the first time that I meet anyone, excuse me, in the sense of this is coming for their intake, the first meeting, I shake hands with everybody. After that, though, I do tend to follow the lead. And I think it's something where, when people do initiate contact, it's curious because I think, again, the idea of where, sometimes it's a sense of closure. This is like how we end, so to speak. There's kind of an indirect formality of that too. But it is trying to understand what that means to them in regard to, excuse me, if a client initiates a hug, in the next session, what was that like? What was your experience?
Yeah,
because we can't be assumptive.
That, right? Yeah.
So it's another way to enter, I think, in terms of their experience of what's happening, because we can still be doing good and unintentionally, causing harm.
It's a great opportunity in a session and afterwards to process something that most people don't get an experience of with their own relationships and their families, like talking about how, because it could be awkward, right? But to be able to like talk about it, about something awkward and be okay, I think is really, really helpful for both, patient and therapist. We're also in a unique position. I mean, not that other psychologists or therapists don't run into this, but like we all have our own parishes. Mm-hmm. So like it's pretty common for Catholic therapists to, the referrals come from our own community, which is great. But we're likely to have much more intersection with our patients outside of it. So we have to be very clear and mindful. And I talk to my patients, and when we start the relationship, okay, what's it going to be like if when we interact outside? You see me at Mass, you see me at the grocery store, and everybody has different preferences. Because I have some patients who's like, do not look at me at Mass. Right. Like after Mass, don't even acknowledge me. Don't come and shake my hand because everyone knows you're Dr. Klafke. I'm your patient. I'm not comfortable with that. Mm-hmm. Others I know are like offended if I don't at least say hello.
Right.
But it's good. It's kind of good to know that and set those up.
And some of them are like, Marlene, come here, Marlene. I want to introduce you to Dr. Malinowski.
Yeah.
He's my therapist.
Right.
And okay,
Yeah.
So there's all kinds of reactions.
Yeah, definitely. I've had a really wide spectrum on that. That's true.
Right, and it could be a barrier because a lot of people may not want to work with you because they think there's a great likelihood that I'll see that professional, so I'm going to go somewhere else. And
right.
Understandable, but
well, and I think that goes back to Jerry's point. I mean, in a way, the sense of where trust, safety, like, do they initiate? So it's a sense of, we know that should exist in time and space. We're not going to violate that, the sense of your privacy. And if they initiate that, that's something, we can talk about too. And I think some of this, Mark, you're really getting into something that's important here, where some of it is, or still is, the stigma of working with a mental health professional.
Mm-hmm. Sure.
What that means, and I think it's evocative for lots of reasons. Mm-hmm. But it's a sense of where I think really the concern is this sense of illness. What does this mean? Am I bad, basically? Mm-hmm. But I think that I think we would probably agree this collectively, a sense of where we see some part of the work that we do in the sense of health, growth, potential. Mm-hmm.
Because we all are wounded, right? It's part of living in a fallen world, right? So it's not like, I lost my train of thought.
Maybe you're talking about being aware of our own stuff too.
Yeah, we need to be aware of our own stuff, but it's not like there are the folks that have, those scary words, mental illnesses, right? And then there are people that don't have mental illnesses, right? And they're just two different camps, or anything like that. It's not like that.
Like a leper type thing. You go with the bell, unclean.
Unclean, yeah.
Right. It's interesting, the difference too, like between what I observe, like in psychologists, and maybe marriage and family therapists, at least historically. Because if you look at some of the great, marriage and family therapists, like a Virginia Satir or a Carl Whitaker, some of these people, they're touchy. Mm-hmm. They're in there with the people. They're down on the ground playing with the kids. There's not a problem hugging. There's not a problem touching. And if there's an issue that comes out of it, then it's processed, right?
Right.
But it's very much, you're in with the system. You're part of the system. You're a person. You're a human. You're not some kind of alien object that has to act strange around normal human behaviors, right?
Well, poor Jared. Sorry. No, I love it. I can feel the passion, man.
Right.
I run a group, and all the guys hug each other after. So I'll hug. It would be weird if I didn't.
Right.
Right.
Yeah.
If there was a problem, then you talk about it.
Yeah, I'm really grateful for you saying that, because I'm a little bit more in that camp myself, right? And some of the styles of therapy that I came up learning and tend to practice are more humanistic, and touch is more of an acceptable thing, but you do have to have that space to be able to process it and adapt if it's triggering something or it's counterindicated for some reason.
And sometimes the attitude would be, and if it triggers something, wonderful, let's work on it, right? It's an opportunity.
Yeah. Yeah,
If you
exactly.
create a sterile environment, you're not going
Right.
to have those opportunities.
Right, right.
Well, and you're talking about something too that I think is unique to all of us is a sense of flexibility.
Yeah.
So I mean, we may practice somewhat differently, still with sense of good, whatever that is, but the way that we actually get there may be different.
Yeah.
Well, I think it also depends on the person and the clinician.
Sure.
Right? There's
Sure.
a lot of variations in terms
Yeah.
of just the styles of the clinician, kind of who they are, as who each clinician is as a person, and that has a huge impact on this
Sure.
as well. So
I want to go back to a point though that you were making, Mark, about contact outside of therapy and how we handle that, because it does come up a lot, especially in the Catholic world. Being a Catholic therapist is a little bit like being a small town therapist, right? Because our patients come from our parishes and other things that we're involved in, and it also raises the question of who can we take on as patients and who can't we, right? Because we have to have a certain amount of space and objectivity, right, to be able to do therapy. Like we can't do therapy with family members and friends and close associates and other people that maybe we could do good work with. It's still not a good idea because of the various complications that can arise. And that comes up regularly. People call in. Yeah.
It can feel artificial. It's like, why won't you help me? I'm asking you because I trust you and I know you well enough to know that you can do this.
Right. Yeah, I don't know about you guys, but I have a hard time when I have to say no to those cases, because it's like, I want to help this person out, right? I know them, or I know something about them, and maybe even I think I could help, but I know it's not in their best interest, and it's.
I also think about it in terms of my boundaries, what's in my best interest, because I don't really. I like to have spaces where I'm not at work. I enjoy, I don't have a problem seeing a client at church or something.
Right.
But in general, I like to be able to not always have that hat on and to just be at church and just be in my neighborhood. Like I don't want a client on my street necessarily either.
Right.
If it happens, it happens. It's fine.
Right.
But I'm going to protect my own kind of personal space.
Yeah, absolutely.
well, and there's that harmony around what's best, right? This is a basic Catholic principle, that if it's best for one person, it's also going to be best for the other person, right? So it can't be that it really is best for that client to see you, Andrew, but it's not best for you to see that client, right? That's not a possibility within Catholic thinking.
Because we believe in divine providence.
Right.
Yeah.
So that is a useful way to think about it, because it may not be clear what's best for the client, but it might be clear what's best for the clinician, right? And then that can help inform that decision about how does that relationship start, or how does that referral get made to some other clinician, right?
So my spider sense starts tingling when I'm feeling like I'm being pushed to do something outside of my own boundary, which then should also signal, hey, there's something unhealthy with the client too. So,
we start to rationalize things to make them seem better than they are. They're really not that good.
Right.
Yeah.
What I found reassuring sometimes for potential patients who, like you said, you have that sort of, there's a request, but there's enough of contact either directly or a friend of a spouse or child or somebody. What's reassuring sometimes is because I think there's a tendency for them to think that I'm trying to just attend to my own discomfort, and that can feel very rejecting. But say I think something you're not realizing is you need the freedom to be angry with me in session. You need the freedom to be upset or to feel that maybe this wasn't the best fit for you therapeutically, and not have to hold that back, which is really healthy to be able to engage that, which you're going to likely have greater freedom with someone you don't have that relationship with. And so it's a way of protecting them. And I think someone's hearing that is reassuring. It's oh, okay, I can see now operationally how you're taking care of me in that. It's not just about.
That's a great point. And I think it's kind of where some of this is conceptual and also stylistic, but it's a sense of where, because we value the relationship so much with the person, we want to protect that for their good. And it is something where sometimes we'll have situations where you could justify or rationalize in some ways how the boundaries are okay if they overlap. And I think that's why it's so important to take it back to the relationship the person you're serving, your patient, in the sense of what does this mean for us? Like, how would this affect us? And so it's where people may, almost reactively consent, but then if you pause and understand it, then you can fully consent, I think, as far as both parties or not. And sometimes we agree to disagree with people. Because I get a lot of that. I don't know if you guys do, the sense of where, I'm working with one, it's like, my wife or my husband wants to come in, or it's something where you have these, potential dual relationships.
Right.
And that will naturally or unintentionally kind of bleed into the work that you do. So it's not that we deny because we don't care, it's because we care that we may say, we see something more, which is important for you.
Again, at least ideally, that's if we're aware of ourselves, right? If we're really spending our time in prayer, on our spiritual development, but also on our own natural human formation, right? It's not just the spiritual realm, it's the natural realm as well, right? And so, I don't know, maybe that's a topic that we could get into, the next time that we all get together.
Well, because we have to have some degree of self-knowledge if we're going to have self-gift.
Right.
And if we're not, if we're unaware, even the spirit of doing good, we can cause harm.
All right. Well, let's pick it up with that when we all get together next time. So, guys, remember what shirt you're wearing. All right. Try to bring the same clothes. Try to bring the same clothes, and we'll sit in the same spots when we do the next segment.
All right. Sounds good.
Very clever.